Polycystic Ovarian Syndrome, PCOS, is one of the most common endocrine disorders in individuals of reproductive age, particularly women. It is characterized by hormonal imbalances involving hyperandrogenism, ovulatory dysfunction, and sometimes polycystic ovaries on imaging. PCOS is a diagnosis of exclusion. Other causes of irregular menses and hyperandrogenism must be ruled out. The disorder has significant reproductive, metabolic, and psychological implications. PCOS arises from disruption of the normal hypothalamic-pituitary-ovarian axis. In a healthy cycle, the hypothalamus releases GnRH impulses that stimulate the anterior pituitary to secrete follicle-stimulating hormone, FSH, and luteinizing hormone, LH. FSH drives follicle maturation by acting on the granulosa cells, which produce estrogen, while LH stimulates theca cells to produce androgens that granulosa cells then convert into estrogen. This balance between FSH and LH allows one follicle to fully mature, ovulate, and form the corpus luteum, producing progesterone to regulate the endometrium. In PCOS, however, GnRH pulsatility is altered, favoring LH release over FSH and producing an elevated LH-FSH ratio, often greater than 2:1. This hormonal imbalance causes theca cells to secrete excess androgens, while the relatively low FSH level prevents full follicular development and estrogen conversion. Insulin resistance, a hallmark of PCOS, further amplifies androgen production by stimulating theca cells and decreasing hepatic sex hormone binding globulin, which increases circulating free testosterone. The result is hyperandrogenism, manifesting as hirsutism, acne, and alopecia. Follicles begin to develop but undergo arrest before reaching maturity, creating the classic string of pearls appearance on ultrasound. Without dominant follicle selection, ovulation does not occur, leading to irregular or absent menstrual cycles, infertility, and chronic anovulation. In a normal menstrual cycle, estrogen stimulates the endometrium to grow during the first half of the cycle, and after ovulation, progesterone from the corpus luteum counterbalances this effect by stabilizing the lining and preparing it for possible implantation. If pregnancy does not occur, both hormones fall and the lining is shed as menstruation. In PCOS, however, ovulation often does not occur, meaning a corpus luteum does not form, and progesterone is not produced. Despite this, the ovaries continue to make low to moderate levels of estrogen, which continually stimulates the endometrium. Because there is no progesterone to oppose this effect and trigger regular shedding, the endometrial lining grows unchecked in a disorganized manner. Over time, this unopposed estrogen exposure can lead to endometrial hyperplasia, which significantly increases the risk of endometrial carcinoma. Clinically, PCOS manifests as irregular menstrual cycles ranging from oligomenorrhea to amenorrhea, infertility, and signs of hyperandrogenism, such as hirsutism, cystic acne, and androgenic alopecia. Many patients also struggle with obesity, particularly central adiposity, which exacerbates insulin resistance and increases the risk of developing type 2 diabetes, metabolic syndrome, dyslipidemia, and cardiovascular disease. The psychological burden of PCOS should not be underestimated, as affected individuals frequently experience depression, anxiety, and body image concerns, further impacting quality of life. Polycystic ovaries is defined as greater than 12 small, usually about 2 to 9 millimeter follicles or ovary, or increased ovarian volume, greater than 10 milliliters on ultrasound. It is just as important to note that polycysts are not required for diagnosis if other criteria are met. The diagnosis is made using the Rotterdam criteria, which require 2 out of 3 features: oligo or anovulation, clinical or biochemical hyperandrogenism, and polycystic ovaries on ultrasound, after ruling out other causes such as congenital adrenal hyperplasia, Cushing's syndrome, thyroid dysfunction, and hyperprolactinemia. Long-term complications include endometrial hyperplasia and carcinoma due to chronic anovulation and unopposed estrogen exposure. The management of PCOS is multifaceted, emphasizing both symptom relief and reduction of long-term health risks. Lifestyle modification with weight loss as little as 5 to 10% can restore ovulation, improve insulin sensitivity, and reduce androgen levels. Pharmacologic therapy is tailored to the individual's goals. Combined oral contraceptives remain the first-line treatment for those not seeking pregnancy, as they regulate menstrual cycles, lower LH-driven androgen production, and protect against endometrial hyperplasia. Anti-androgens such as spironolactone may be added to address hirsutism and acne, but require concurrent contraception due to teratogenic potential. Metformin is commonly prescribed to improve insulin sensitivity, reduce circulating insulin and androgen levels, and may restore ovulation in some cases. For individuals desiring pregnancy, ovulation induction agents such as letrozole or clomiphene citrate are effective, and assisted reproductive technology may be considered for refractory cases. Because of its chronic nature and multifactorial impact, PCOS requires ongoing monitoring for metabolic and cardiovascular complications, counseling regarding reproductive planning, and attention to the emotional and psychological well-being of affected individuals.